At this time, I want to acknowledge where we are working and living from. It is our privilege as a BC Centre to work with humility and respect alongside, of our partners across this land, colonially known as British Columbia. And probably even on our chat here, we have a wonderful representation of partners and individuals from across our province. We acknowledge that our work takes place on the traditional and unceded territories of many distinct First Nations whose values continue to guide us. We recognize too the Métis people and the Métis chartered communities, as well as Inuit, urban Indigenous peoples that live across this province on various traditional territories. I am joining you from the Coast Salish people in the greater Lower Mainland Vancouver area, and recognize and am grateful to live on this land, to work and live and play. At this time, it is my privilege, next slide please, to introduce to you our two guests. And both of these women are from, right now, our host site, the Prince George Hospice Palliative Care Association. So first of all, Donna and Erin are both in the same room there. So Donna, you want to wave your hand? There she is. Donna, thank you for joining us today, is a distinguished healthcare leader with over 4 decades of experience. And you may know her, and she is recognized for her global contributions and passionate, unwavering commitment to compassionate care. Her work began with Mother Teresa Hospice in Calcutta, and then she became a director of care in Nunavut, a slightly different territory, I may say, than from India to Nunavut, where she was able to address unique northern healthcare needs and challenges. Now, for the last 10 years, since 2015, Donna has been the executive director of Prince George Hospice Palliative Care Society and has expanded the services to include BC First Home Hospice Program. This enables people to die with dignity at home while reducing hospitalizations and emergency visits. Alongside of her is Erin Connelly. Erin is the operations director at Prince George Hospice Palliative Care Society. She has a Master's of Education degree in counseling, is a registered clinical counselor, and has over 20 years working for the Indigenous Social Services agencies. She's also a board member at the Sunatatsun Community Health Center and a volunteer for the Two Rivers Arts Center. So we have today two very passionate people who enjoy and are passionate about working with wellness and caring for their community. And I think this is going to be a really informative time. So I just want to say welcome to both Donna and Erin. And it's not unusual, but we do not have a slide deck today. Both Erin and Donna will be presenting in a conversational style. And so I just want to welcome you both and turn this session over to you.
Thanks a lot, Melody. We're actually very excited and happy to share. Oh, first, I do want to acknowledge we are on the unceded territory of the Clélé T'enneh, and it's our privilege to be able to serve within this community. So I'm just going to give some sort of foundational information on the Prince George Hospice Palliative Care Society. We feel that we're extremely privileged to be able to do this work, and not only just do the work, but also enhance and add to the sector and help support the work right across the province. So we have been a society for close to 40 years and have had the Rotary Hospice House for 30 years. We were the very first standalone hospice house in BC, just due to the foresight of really strong advocates for hospice care in our community. Had they not had the foresight to put together this hospice house, we probably wouldn't have the organization that we do today. So we're, again, very thankful for their foresight. And with that, we spent probably a good, 15, 20 years really focusing on care in the hospice house, trying to develop the policies, trying to support other hospices as they grew, and really just had that focus on end-of-life care. And then for the past decade, we've really been fortunate to be able to look outside into the community and look at what other needs they may have. And so we've really grown our community programs, which are the grief and bereavement programs. 10 years ago, I think we only had one. We had a drop-in program and a 6-week formal program. Since then, we now have multiple programs uniquely supporting people in their grief right across the north. We're doing virtual programs as well as. But what we were doing some of these programs, what we were finding is we had people that were coming with complex grief because they had made the promise. I promised my husband that he could die at home. However, in the middle of the night, when the crisis hit, the pain became too much, or they became scared, they made that phone call. They made the phone call, and they got brought to emerge, and they ended up dying in emerge. And people have really struggled with, having to not be able to provide or fulfill that promise. So my very brave staff said, well, what can we do? And we sort of looked at each other and we thought, well, we can do home hospice. So that really became out of this need to support people to die in the place they choose. Our health authority at that point only provided home care until like 7 o'clock at night. So there was a huge gap in the nighttime. So once we made the decision, and we were very fortunate that we were encouraged by the board to move this forward, in spite of the fact that we had zero funding. So there was no funding involved in this. This was a wish and a prayer, and relying on some reserves that we had acquired over the years. So that sort of is the foundational piece of how we got to even think that we may want to attempt this. So then became the hard work of, okay, how do we actually create this? And that's where luckily we had Erin that could help us sort of turn what was into an idea into actually care. Do you want to talk a little bit about how we even just started?
So for about a year before home hospice began, we met regularly with stakeholders. So that included physicians and Northern Health leadership, ambulance services, all kinds of folks, Indigenous representation, because we had this idea of what home hospice could be, but that became further informed by the stakeholders who were coming to the meetings. So for example, we were talking about having nurses in the home hospice program to work with a care aide from the health authority. And by meeting with the stakeholders, we realized that wasn't a possibility. The Northern Health care aides need to report to a Northern Health nurse, and no doctor wants two nurses reporting to them. So those stakeholder groups were very helpful in informing the community what we wanted to do. Everyone agreed there was a gap to be met. We could all agree on that. And then it was the logistics moving forward. Want to add to that?
Yeah. And also, I think one of the things is when you're working in the health sector, there's a lot of that's my lane. That's what we do. So we came across some pushback initially. There was some sort of feeling from Northern Health that maybe we were intruding on their work and what they need to do. And so we had to also really carefully navigate. I don't know if I'd say it was the feelings of them, but that feeling that we were entering into their space and that they and implied that they weren't doing a good job. So really it was trying to say that it's about enhancing the work and being able to, get people to where they need to be, and then also allowing them to have more resources to look after the acute care side of care. So that was a large part of the navigation, was just getting people to give up ownership and to trust that we could do it.
Yeah, and probably a well-known statistic among this group is that most people wish to die at home, but most people are not dying at home. So the evidence is there for a program like this. And in home hospice, most people do die at home. So we are achieving one of the many goals of home hospice in this program.
So that took us to just sort of getting together our stakeholder group to look at what needs to be done, who is our target audience, how do we put boundaries around how far we can reach out, how many people we could serve. So ideally, our initial thoughts was one nurse, 10 people in the community, they would go and they would be available 24 hours a day. And then as we sort of dissected the work, that's where we realized that we couldn't have a nurse alone program, that we really had to have nurse, care aide, grief support worker. And that's one of the things that is integral about this program, is that grief support comes in and does a lot of that anticipatory grief care or supporting the family with just holding space and talking about what's next and letting them know what they can anticipate over the next days or weeks or even months. We've also included volunteers, which today we haven't used a lot, but we wanted to make sure that there was an opportunity for people that just wanted someone to maybe sit by the bedside and hold vigil, because we can't spend hours in a household, but we could certainly have trained volunteers come in and provide respite or just be there, especially when it comes closer to end of life and there's more of that fear and grief that's manifesting itself. So that's sort of how we determined what our skill mix would be. We didn't know what the capacity would be of the staff, whether it would be 5 clients or 10 clients. Upwards, we've had 12, 9
or 10.
9 to 10 has been, the most that we've had on our list at one time. And that seems to be a good number, but again, depending where they are in their journey, we can flex up or down. We also were quite clear that we would stay within the community boundary so that the driving. However, we have nurses that care deeply, and so we've extended actually where we go. We go as far as what, 25, 30 miles out?
Yeah, even a bit more.
Even a bit more. So we can actually go and visit some of the very remote homes that home and community care doesn't have within their mandate anyway. So these are people that have very limited service.
Mm-hmm. Let's talk about physicians a little bit.
Yeah.
Yeah, so while working with physicians in the stakeholder group, we had some surprises along the way. So here at our hospice facility, the physician follows the patient and continues to care for them while they're here. We don't have our own physician. And the model was to be the same in home hospice. But at the time we were talking about home hospice was 2022. So we were coming out of the pandemic. Doctors had a lot of pressures and stresses and political issues going on. And not only did they not want to learn about a new program, they were really like, we can't just handle one more thing. So we had planned this, like, let's roll this out. This is a celebration of filling the gap. We'll have all these presentations and dinners and it'll be a wonderful thing. And none of that was able to happen because they weren't interested in coming to the table. It was quite disappointing because we all agreed there was a gap. But it was a much bigger thing than the physician's relationship with hospice. It was a physician's relationship to the province and all kinds of things. So we managed to overcome that by working with physicians when we could, but really everyone else. So social workers and community and nurses to educate them about the program. And if a patient wanted the program, their doctor had to agree. So doctors began to experience the program. And over time, doctors have become our largest referral source for home hospice, but it's definitely been a bumpy road to get there.
So anyone that knows me, we don't accept no. So it really was a matter of pushing forward until they could see, because we knew that this was going to be a game changer for people in the community. But again, for the physician, they just didn't want to have one more thing. But what they learned, well, first of all, because our whole objective was to reduce hospitalizations, to allow people to die at the place of their choice, to bring quality to that journey of end of life, and to reduce the admissions to emerge. So the plan was, if they got to the point where maybe they did need a level of care or they wanted to have more support, they would come directly into our hospice house. So they would just transition quickly in. So they said, well, what happens if you're full? And because they were trying to find all the gaps, right? So what happens if you're full and you don't have room for them? Well, they're going to have to go to the hospital then. And so we've created a holding room. So we have a room in our hospice house that in the event anyone from home hospice needs us, they have a place to come. As with any hospice house, the turnover rate is quite quick. We're not going to have to hold anybody for a week. It's maybe a couple of hours or a couple of days that they would have to be in there. As yet, we've never had to use that room, but we do have this room available so that we really can prevent that readmission into the emergency department, which really is where the trauma happens at end of life for people that are at the bedside. What about the nursing staff schedule?
Yes, that's exactly what I was going to talk about next. So yeah, I'll talk about our staffing and what we are offering in the home hospice program. So we've got 12-hour shifts in our hospice program. It didn't start out that way, but that's what's ended up being most desired by staff and most helpful for families. So from 8 a.m. to 8 p.m., there's a nurse and a care aide on shift in home hospice, and they're based out of an office here in our facility. At night, from 8 p.m. to 8 a.m., there's a nurse on call. So this is a small team of nurses and care aides, and the families, there's a shared cell phone that the nurses pass around. So at night or even in the afternoon, they can call a nurse that knows their person, and they can respond with a home visit if that is what is necessary. So we have that flexibility to respond.
So initially we had 24 hours. We had nurses on that were on 2 12-hour shifts, a day shift and a night shift. They were literally twiddling their thumbs the whole night. There was nothing for them to do because by putting the expertise and the grief support and the volunteers around people, they can anticipate what's going to happen at night. There's no surprise. They know that they're going to see an abrupt change, and if this happens, then we implement this. And so all of the orders and emergency orders are pre-done, and the family is educated that if you see an increase in pain, well, you can go ahead and give this medication or whatever. So we really felt that being on call has sufficiently managed the needs.
Yeah, we've been tracking our home visits in the night, and in a calendar year, there'd be approximately 20 home visits at night. So not nearly as much as we expected just by doing what Donna's describing. So the program offers scheduled visits as well as unscheduled crisis response visits. Equipment, supplies, emergency medications are provided. Everything is free in this program. There's no cost. And then, as Donna mentioned, personal care, nursing care, grief support, and respite are also available in the program. Do you want to mention anything before I move on to evaluation?
No, I think the whole thing is moving forward and adapting to things as they come. Did we have all the right things in place before we started? Absolutely not. We ran into things where we didn't have the right medications in the emergency box. However, we would then work with our physician colleagues and we would adapt and change. Pharmacy was huge in helping support us on what those emergency boxes would look like, how we would exchange them, and things like that. So there was a lot of PDSA cycles within what we were doing. What could we do better? What could be done differently? Do the nursing care aide have to go on every visit together? Can one go on their own? And again, absolutely depending on the needs. So we also had to purchase a second car so that we would have a second vehicle for them to move forward. But no, I think, again, the whole thing was keeping it moving and making those changes as we came across them, than trying to have a perfect program in place.
Yeah, so the early days, I mean, the first couple of years, we had monthly meetings with the staff to make sure we were on the same page about what was and what was not working, keeping our procedure and policy updated. And now we're a little more stable at 2.5 years in. So we've also had a partnership with the University of Northern BC, while we've been doing this work so that we can show the impact, demonstrate the impact that we know we're having, we see it, and the university is helping us publish articles on the proof of all of that. So that's involved a bit of extra work for us. So for the first couple of years, we did daily reports that were completed about how many visits, what type of visits, how many visits per client, so that we gather that type of data. When a client ended service with us, we'd fill out a closing file summary about, were there gaps we weren't able to meet? Did they die at home? If they didn't, why didn't they? So we could look at that sort of information. And then staff and clients' families were interviewed by a researcher, if they agreed to do that, about everything home hospice, what was great, what was not great, and that information was reported back to us so we could make quality improvements.
Yeah, and I think that what's key there, I mean, we're thankful for the BC Centre because I think a lot of our research and academic work comes out of there. But within the sector itself, very little gets shared because we're so busy doing the work. So that's the relationship with the university allowed us to actually get published papers done so that we can share this information and help the knowledge transfer right across. So I have to say, I recommend anytime you can partner up to get that information so that it becomes shareable is really important to our sector. Our sector is becoming much more sophisticated, so we need to create these papers and articles and all of that. So yes, I think they're looking for the articles. Yes. So Erin has those and she'll send those out, the links to the articles that we have. The other thing, again, it was a challenge for the initial year because the nurses knew that it was a pilot project. And so they were only on temporary hire, right? Because we didn't know whether it was going to be successful. So that made a bit recruitment a challenge because people don't want to leave permanent jobs for a temporary job. So part of our big work was to find out how do we fund this, right? Because it was not funded by the ministry or by the health authority. We did negotiate with Northern Health, though, that all of these clients were palliative and on palliative benefits. So they reimburse us for all supplies. So we get all of the supplies reimbursed for what we do. And then because we're very fortunate, our biggest revenue source is a dream home lottery that brings in a substantial amount of revenue to do what we do. So just up the tickets and add another 50-50 because in fairness to our staff, we want to secure their employment as we continue to negotiate with the health authority. Like the negotiation with the health authority doesn't stop. We're trying to see if we can scale up and take over all end of life and palliative patients within the health authority. But again, those are ongoing conversations. But we really worked hard that we didn't want the fact that we were not being funded as a barrier to what we were doing. And since we've done it, I just want to tell you one beautiful story, just because stories too. And Erin has some beautiful stories because everything is about what we do is about the stories. So we had one young woman that was referred to us. I think she was late 30s, early 40s. And she had multiple instances of cancer, but this cancer returned, and now she was at end of life. And when we got the referral, we phoned immediately to see if we could come and intake. And the husband says, we are just on our way to emerge. She is in such pain. She can't deal with this. This is our third visit to emerge in the week. We'll phone you later. The nurse said, give us 5 minutes and we're going to be there. So they went and they met her husband. It's going to make me cry because I knew her. And they symptom managed her. They got her pain under control. It was the first time she could be at home comfortable. She was so comfortable that with her partner, they said, to hell with it, let's get married. And so they managed to get married, have their wedding and all of that, because her symptoms were manageable. She was comfortable. And it was just, such a great hospice story. It's the reason we do what we do. And she had been a great friend of hospice before she was sick. She had helped us with lots of our staff. So she was well connected to us on that volunteer level. But to be able to give her that gift was huge. So sorry. Everybody knows I'm very emotional.
I think if I can, thank you, thank you. It's a wonderful place, and that is the heartbeat of the work that you do, Donna. That's actually the story. I'm
Yes.
wondering if we should pause now because you have shared so much of such
I
an
know.
amazing journey. So let me try to recap a little bit. So what Donna and Erin just shared was really the visioning process, how they saw the need across the scope in their city and their community, the need to establish some partnerships to talk about it with partners, then a whole planning phase about what it meant to build with partners, not just funding, but what were the needs, who are the audience, who would be the patient, who would be the volunteers. Then they talked about the nimbleness that was required to pivot as they were implementing all kinds of things that they needed to pivot and be flexible on. There's an evaluation process and a partnership with UNBC so that there's some learning that continues. There's a shared learning that can be shared as well as just sustainability for their program going forward. And so the end result is to give exactly what she said, less hospital visits, increase the quality of life, and make the end of life journey as comfortable and managed for the patient and their family and their caregivers as possible. So I just want to open the floor right now. If you have a comment, a question, we have about 21 people online, so you know. I'm just going to ask you to unmute yourself. A lot has been shared, so this is your time to maybe just introduce yourself and ask a question or share some of your own insights. Anyone want to jump in right now? I'm looking to see, but if I haven't tagged you, just introduce yourself.
I see Jody has her hand up. Go ahead, Jody.
Yeah, go ahead.
Hi there. Thank you so much for your presentation. I have a whole bunch of questions. And some of them are like minutia questions. I'm coming to you from Victoria. I work in Victoria, BC. I'm just wondering about the when the nurse is on call overnight, where are they physically located? Do they do that call from home? And I know that you mentioned that you have that shared cell phone that goes around. So I'm a bit curious about that. I was curious about the grief worker you'd mentioned. I'm not sure if that was envisioned originally and if that is part of your program and if they go out on the calls with the team or not. Um, and and I had some questions about the drug kit and how that works and if that's a kit that is dispensed per patient. Yeah, so those are just some of my questions.
Sure, I'll answer the first couple and then I'll pass it over to Donna. So yes, the nurses at night go home. So they've got the cell phone. They've also got a laptop with a SIM card, so they can chart in between houses if they'd like. They can access our client. Yes, we've got the Info Anywhere software program, which is a hospice developed client software. So when they're at home and they receive a call, they can look up the client's chart and see everything in real time. So they can bring that with them. So they can, it kind of depends where they might live. If they live close to the client's house and they're quite familiar, they could go right there because as we've said, there's the supplies and the kit are right there. Or they can come to hospice, pick up the hospice car and go out to the house. So there's a couple of options for them. The grief staff do go out on calls. They do go out to meet every family to build a connection, to see if they're interested in some grief support. And I'll pass it over to Donna to talk about the drug kit.
Yeah. So again, we weren't, and that's actually ongoing, right? As things change, symptom management changes. But yeah, so we get our emergency orders from our physicians as we intake someone. And so they're pretty standard emergency symptom orders. And the pharmacy does the kit for us. They do it for the individual patients, so they're specific, which again, because of palliative care benefits, gets covered off for there, so there's no charge with that. And so in the event that they're required, it gets opened and we resupply. Initially, though, it was only we didn't want the staff, or we didn't even think it was legal for the staff to transport those kids. So we had to have families go and pick up the kids themselves. And when we did our evaluation, that seemed to be one of the biggest challenges the families felt, was actually getting the emergency medication kits to the home. So now, through a lot more research and understanding what the legalities of, the nurses actually bring that kit. So the kit comes to us from the pharmacy to the hospice house, and then it can get taken directly to the client. And as we move forward, we move things into the kit and we move things out of the kit. At one time, we had phenobarb in. We decided that wasn't really the best choice, and put midazolam and Ativan in. So we've done a little bit of work with our palliative care consultants and the palliative team to find out what are the most appropriate emergency drugs. So right now, I think we've had a standard kit for about 6 months. About
Like since the last change? Or?
Yeah. So, and then it just goes into the home. And one of the latest changes that we've done is palliative sedation. What does that look like when you're in the home? So we're just in the middle of revamping our policy on that. We're no longer going to allow palliative sedation in the home. If someone is requiring palliative sedation, they'll come into the hospice house where we can clearly monitor them more closely than to ask the family to give a high level of phenobarb and assess their arousability and all of that sort of stuff. So right now, until maybe things change or our comfort level change, we no longer, I think that's probably the only thing we don't sort of support in the home is the palliative sedation. Okay. And if the family so chooses and the client wants made, we're there in support of the family and the procedure. We don't do the procedure, Northern Health does, but we, again, are there supporting the family through that.
Okay.
Thank you.
Any other comments, questions, observations? Perhaps it's a query of delivering palliative care in a home setting in your neighborhood or your community.
I think Dale has his hand up.
Go ahead.
Yes, thank you very much. I'm joining you from Nova Scotia, from Halifax, and we're trying to actually develop something like that. And we've been thinking about how we can make it work. So hopefully I'll be able to connect with you after this program as well to learn more. One of my questions is, you've mentioned that volunteers are also involved in the program and that you provide respite services within the homes. Do volunteers, perhaps, are they involved in any hands-on care in any way?
Hi, thank you. No, volunteers do not do any personal care. They would not be feeding someone, anything of that nature. So in our health authority, the care aides working for Northern Health also provide respite. So to provide a comparable service, we also had to bring respite to the table. Otherwise, no one with respite was going to ever come to home hospice. They wouldn't want to give that up. So our care aides do the respite. And then once we learn more about people and their homes and what's going on, we try to integrate volunteers to take on some or all of that respite. We've also had volunteers. We had a gentleman who, of course, was dying because he's in the program, who adopted a large breed puppy. And as he declined, we had volunteers come in to walk this dog 3 times a day because that was very necessary. So it's been quite flexible for us what volunteers are able to offer.
So when you say care aides, are they able to do personal care and things like that?
Yes, they do personal care.
Personal support workers. I don't know, they've got different names across. So the
All right, yes, exactly. Thank you.
Cynthia?
You just muted Cynthia.
Hello, everyone. Hi, I'm Cynthia Lapointe. I'm from Montreal, Quebec. I work at the Teresa Deller Palliative Care Residence. I'm just wondering, when you're talking about your volunteers, is there like a specific training that you offer them in order to be part of this service when they're going into the home? Is it background, or is it an actual training that you provide?
Yeah, that's a great question. So we have a huge volunteer program here in Prince George. And so there's a standard orientation for everyone who is coming in. And then there's additional orientation if you're going to be interacting with clients. And then if you're going to be in clients' homes, there's a policy and a procedure about like safety checkouts and checks in and emergencies and all of that. So that's another layer that happens. You want to add to that?
Yeah, no, I think that looks perfect. Yeah, we layer our training depending on what the volunteer is doing. Our volunteers do so many things. So they all get the basic one everybody does that's replicated the Canadian Hospice Palliative Care volunteer training. And then we layer on depending what their specific program is or volunteer opportunity they want.
Okay. Okay, because we use, which is yours from BC, and we're very proud to use it, the NavCare program. I'm sure you've heard of that. And, the volunteers are trained for NavCare and they go into the homes, but not always for palliative reasons, but for isolation, grief, those kinds of things. So that's why I was asking, because
we had done the NavCare as well, so we've incorporated a lot of their work. We're just in a different NavCare program now, but yes, absolutely, they sort of have set the level up on that home visiting volunteer work for sure.
Yeah. Okay, thank you very much.
So I think Carrie is next. I invite you to unmute.
Hi. I missed the first few minutes of the presentation, so I'm sorry if this is a question that someone else or that you answered already. I don't even know if it's a question you can answer. But my name is Carrie. I'm a nurse from Northwestern Ontario, and I'm part of a community group actually that's looking to start a hospice residence. But we've had the thought where it's like it's going to be a while before we can get a building, and not everyone always wants to be in that building. So I guess I'm curious about your process for providing care in the home. Like, is your staff paid? And if so, who pays the staff? Who are they employed by? What's your funding stream? And I know it's a different province, but I'm just trying to get a handle on how that
And
works.
I've often thought, there's so many people dedicated to getting a hospice house, but it's like, go into the homes first, start in the homes. I mean, that's how Hospice Society started. We started with volunteers in the homes and holding vigil, and then it morphed with the hospice house. But no, our nurses are our nurses. They are employed by the Hospice Society. We actually have our own collective agreement of how we pay them. For Hospice House, we talked about that is partially funded through the Health Authority, but our home hospice is not. I think it's something organizationally and as a sector we should be out there promoting, but because we were the first in BC, there wasn't that momentum. But I think Kamloops now has one.
Kamloops, or is it Vernon?
No, North Okanagan just got that's Vernon. Yeah.
It's Vernon.
So as we get more, hopefully it will support the ministry to fund us. But what we know is that the home hospice program is a third of the cost to run than it is the hospice house.
Wow.
Just because bricks and mortar and all of that, right?
Yeah, and I mean, I know that hospices even are less to run than a hospital setting. So, you've got your kind of layers of how much it costs. And I had thought that maybe that would be a way that we were going to be a charity, but maybe we could provide some care in the home and then eventually get a bricks and mortar place, because that I think is needed for our area.
Yeah, and lots of work is being done on advocacy for hospice care throughout the country. We currently have a PhD student working on the value add of hospice care in comparison to acute and hospital settings. So sort of sharing with everybody, it costs this much a day for home hospice versus if they were in hospital versus if they were in home and community care. So we're getting those numbers together to go to the health authorities and the ministries to say, we need to have a better funding stream because it is cost savings. They don't necessarily care that it's a better quality of care. It's about the cost savings to the health sector.
Thank you. Dale, you have your hand raised again. Go ahead. And then Jody.
Yes, thank you. As I'm listening, I get more questions. Thank you for all the information you've provided. How do you differentiate yourself from continuing care home nursing? Have you noticed any overlaps? And if you have, how have you been able to address those? Yeah.
If they become a client of home hospice, they stop the services of the community care. So they're no longer, so there's no redundancy of services. So we have a relationship with the health authority that when someone chooses to come into home hospice program, we notify them and they stop or cease the services there. The only time that it's a little bit different is if the family themselves are paying for care, if they're bringing in their own care aides or things like that, they've got their own private care happening, and that's where we're sort of navigating around that a little bit, and we allow the family to determine exactly what they want from us and what they want their paid care to do. So there's no overlap, because that was why we couldn't have the care aid RN model. We had to put it together because the overlap would be just too difficult to manage.
Yeah, thanks.
Jody and then Daniela.
Just a quick question. I just was wondering, for the nurse that you have working at the home hospice, is that an RN or an LPN? I'm assuming an RN, given there may be initiation of new medications and things like that, but just wondering.
So we did a lot of research on LPN scope since the pandemic because it really impacted our staffing and we had to be a little more flexible. So here at hospice in the facility and in home hospice, we use LPNs or RNs. And we're aware that in the hospital model that's just down the street from us, LPNs report to RNs and are not allowed to do all of the things that they are trained to do. But their scopes are very nearly identical these days. There's only a couple of things that we have solidly found that LPNs are not able to do. So we have an RN clinical lead who oversees all of our nurses in both programs. But yes, we have LPNs in the program.
I see Daniela.
Yeah, just a quick question. I'm from Salmon Arm in BC. And I think you may have alluded a little bit, but the crossover between home care that's health authority driven versus you guys, because I work in a home, basically it sounds very similar to your home hospice program, but it is run through our home community care office. So we predominantly, actually exclusively, only see end-of-life clients in their home. So I was just curious how that was different up in PG.
Yeah, it's quite different here. So home support and home nursing see people across the lifespan. Home hospice is the only program that is only seeing people at end of life. So the nurses, of course, become experts in end of life hospice care.
And and why we started it again was because the home and community care stopped at 7 p.m. at night, and then the only alternative to care was the emergency department. So we wanted to fix that gap and allow them to stay at home. And that's why we instituted the home hospice, because the home and community care weren't doing the 24-hour service.
Okay, so they do have some end-of-life clients, they just don't have the around-the-clock support.
Correct, yes.
Okay.
Correct.
Okay.
Yeah, they do. They have end-of-life care, of course. Yes, they do that.
Yeah. Okay. Interesting. Thanks.
Okay, so there is a question in the chat as well from Carrie. Where can I access the information costs that you've mentioned? So I gather that's still being developed, right? This is still being assimilated?
It's being developed, but we also have done sort of our own more not as deep cost analysis, just so when we do go to the health authority, when we do our briefing note and our proposals, we've done that cost analysis of hospice care, home hospice, and acute care settings. So we have a little bit of that done, but it's not as in depth as what this PhD student is going to give us. And we are also very happy to share any information, whether it's our initial proposal that we put forward straight to our document of our statistics or our policy and procedures, and even our financials. This is something that, I think as a sector, we've always shared our information because every community, deserves to have a level of hospice care.
Well, there's a great deal of interest in this. Jody, go ahead.
Thanks. I was just curious about the transition from home and community care nursing to so is it that people generally are sort of being cared for maybe with a connection with home care nursing until they're needing 24/7 access? And then is that team referring to you? Or you mentioned that a lot of your referrals come from physicians. And is there a time limit for how long people can be attached to your service? Or are you tending to be involved just in the last 2 weeks of life, or just to get a flavor of things?
Yeah, so referrals do come from home nursing. They tend to come from other sources, though. Like as Donna mentioned, there's some feelings about, did this program get created because we're not doing a good job, sort of thing. So we track how many people are coming to the program right out of hospital. So some people are not able to discharge from hospital until they have the level of support that we can offer with home hospice. Some people would not have been able to go home, and families tell us that. Some people are at home with no supports. Some people are at home waiting for home nursing, and some people are at home on home nursing, but are willing to change over staff to have an increased level of service.
Yeah, and I think a lot of it is just because the everything is requiring so much resources that the wait time to even get home and community care can be upwards 3 weeks to a month, and that's just the rapid access. So it's about filling that gap so people can get the care. Our from referral to intake can be as quick as, like I said,
down to 8 hours.
Yeah, down to 8 hours that going to the home. So we provide that in the moment service so people can get home.
And your other question was about the length of time. So this has shifted a little bit over time. We started with quite a narrow criteria, and now it's a wider criteria. So it's not based on PPS, it's based on life expectancy. So if the physician feels that someone has less than 3 months to live, they're eligible for our hospice program.
Okay.
And just to follow up, if they're wrong, I'm saying this because I'm a physician and sometimes it's hard to prognosticate accurately. If they're wrong, then what happens if people are still on your program and it's month 4?
Yeah, we are super flexible. So in our facility, if someone improves, which does happen, we don't want to kick them back to the hospital. We want to hold on to them until they get a long-term care bed if they can't go home. And in home hospice, we've been very flexible to keep people for several months, even in one case a year, because we had the flexibility in a new program that wasn't full.
But if they do decide to go back into acute care treatment, we have had people that have made the decision that they no longer want the hospitality care, they want acute care. So then they do leave the program if they're going into acute treatment or back to the hospital for that. But that would be the only reason. And it happens in hospice house too. Oh, the good news is you're not imminently dying. The bad news is you got to get out. So it's weighing those and trying to be as soft and supportive to people as we can.
Okay, there's definitely an interest to learn more. There's a couple of individuals specifically asking for contacting with you directly about your vision and your policies and applying for funding. So that will be made available. And I think Erin and Donna, we can give out through the follow-up email link that you will get from this Echo series. You will have this series and this recording available. And yes, their contact information is available. Donna, you're open to sharing, right? Go ahead.
Yeah, we're open to sharing, and we would love to invite everyone down to come and see, the incredible work that's happening here, and to share it, and to even just offer us advice on, how we can see and do things differently, right? That's the one thing I love about the work that we do, is everyone is so sharing of information and generous with knowledge. And I think that's why hospice is so good.
And thriving.
And thriving. You know what? We just need the financial backing, but we're getting there. We're closer than we've been. So
we still have a few minutes. If anyone has a comment, perhaps even another story or situation, it's a great time to pop up.
Can I go ahead?
Yes, please.
Yes, I think my question will be for the nurse working on the 8 a.m. to 8 p.m. shift. You mentioned that they stay in the hospice house. Do they have scheduled visits for the day, or what does an 8 a.m. to 8 p.m. shift look like for a nurse?
Yeah, when the program is busier, that might look like 3 visits in the morning that are 2-person care along with the care aide, 3 visits in the evening that are also 2-person care. And in the afternoon, they might be doing an intake, they might be doing nursing follow-up or consultations, or just checking in on caregivers as well.
But they also are responsive. That's the different thing, is if someone is scheduled for, 7 p.m., but something happens at 2 p.m., we're pretty flexible to adjust what we do so that we can be in the moment. I think one of the things that we get recognized for is for that patient that has the unexpected bowel movement, and they don't have to sit there till we will come and we will help support them, so they're not left with that caregiver feeling overwhelmed. Because we also know if a 90-year-old is at home dying, it's a 90-year-old spouse that's trying to look after them. So it's really about being there in support of the caregiver. So we're we can be very reactive to the calls and the needs. So, and then what happens too is if they're not busy, because sometimes we're not that, the care aides and the nurses are in the house here supporting or being part of the team and really feeling very much a part of all hospice work throughout the continuum that we do.
I'll tell a quick story about when the program is not busy. So I was looking for our nurse one day because they were off-site and I don't know what I needed. But I reached her by the phone and she was like, kind of don't want to tell you where I am. And they were taking a coffee to a gentleman whose wife had died some weeks ago and they had no family. So they were reaching out to keep that. He loved the relationship with the girls that would come to the house and he was missing that. And they took him a coffee, which I thought was very sweet.
And I'll just add one more thing that is totally unrelated to home hospice, but kind of is, because the same sort of thing, the staff decide that after lunch hours, they go to the Humane Society and walk the dogs, right? Because they don't do enough. And so this one day, parvo virus prevented them from going in. So they ended up going to the cat hut. So we now have a hospice cat, dragged our hospice cat, because that's just what happened at hospice. So
there's a question from Jody. Thank you, Donna, about what's the population catchment you area. So Prince George is 75, 80,000 people. Do you go beyond that area?
If you're just counting the city, that would be accurate.
Yeah, for home hospice, for our hospice house, we can reach out. Well, we've had them come from all over the country. We've had them from Ontario, Alberta. So as long as it makes sense for them to be in Prince George for family or whatever, our hospice house primarily is Prince George, but we have the whole north and wherever family happens to be from.
Okay.
And can I just ask one
anything
more
else?
follow-up question? Do you have a relationship at all with the paramedics? I'm assuming not, because people are choosing not to go to acute care, but I just wanted to.
Yeah, so when we started the program, we were talking to paramedics because we were told they'd all been trained in palliative care and helping to keep people at home versus coming into the hospital. And when we spoke to their leadership about that program, they said, yes, everyone's trained. No one can do it because of the limited capacity of the ambulances. But they've been able to help us with coming to help stabilize someone instead of going to the hospital, or help to pick someone up that our staff's not able to pick up. They've been very flexible and very interested in home hospice.
And what we have on the fridge of every home hospice client is a little magnet that says they are a home hospice client. So in the event someone calls that ambulance, the ambulance knows and will call us. And that's the way we communicate with them, that it is one of our clients. The other thing that we've just done, which is new for us, and Jody, we may have him reach out, is because of the amount of orphan patients and the capacity of our physicians to pick up one more patient, we have brought on a medical director that will be picking up any of those that don't happen to have a physician so that they can support them, which is, we're so thankful for that.
Well, I see we've come to time. Thank you so much for sharing, both Donna and Erin, an amazing program and pioneers in the hospice palliative care supports for your community. There's many seeds that have been sown, and I'm pretty sure there'll going to be lots of questions coming your way for growth in other communities. So if there's other questions here, by all means, I think we can reach out to both Donna and Erin for further compensation and information, and you will get the link from ECHO as well in the short day ahead. So thank you so much for sharing your time, your wisdom, and your stories, and thank you all of you for checking in today and participating. We hope this has been a valuable time for you to connect.
So my last words are, don't say no, just keep moving, don't accept no. Push, push, push.
Thank you all.